Now let's get into the various types of anemia. And the very first type is the most common type of anemia, and that is iron deficiency anemia. As the name suggests, iron deficiency anemia is caused due to deficiency of iron in human body. How does a deficiency of iron lead to anemia? See, for the formation of hemoglobin, two components are required, heme and globin. And for the formation of heme, iron is required. So if there is lack of iron in body, there is defect in production of heme and there is less production of hemoglobin. So less iron leads to less heme and less heme leads to less hemoglobin. And what is the condition where there is decreased concentration of hemoglobin below the lower limit in blood of your body? That's your anemia. So that is how iron deficiency leads to anemia. See, under pathophysiological classification of anemia, we had various causes of anemia, and one of the causes was due to defective production of red blood cell. Now, there can be defective production of red blood cell either due to defect in cytoplasm production, or due to defect in nucleus, or due to defect in stem cell that lead to the formation of erythrocyte itself. Cytoplasm is composed of hemoglobin, and hemoglobin contains two parts, heme and globin. So cytoplasm defect can occur due to defect in production of heme, and the anemia in which defect in production of heme takes place is iron deficient anemia. The reason being, iron is required for the formation of heme. So if there is deficiency of iron, there is defect in heme production, there is defect in cytoplasm production, there is decreased production, and you have anemia. Alright, so that was it for introduction. Iron deficiency anemia is the most common type of anemia, and it is also the most common nutritional disorder seen widely in developing countries, because it is in developing countries where people with very low socioeconomic status survive, and they end up not being able to satisfy their iron demand, the daily requirement of their iron in their diet. Okay, so the first thing was introduction. Second is a normal iron metabolism. You first intake iron. This iron enters your gut. It then gets absorbed, reaches the blood. Through the blood, it gets transported to different parts of the body where iron gets utilized, and the excess of iron gets stored in your body. The process of absorption of iron is also regulated. So these are the various steps included under normal iron metabolism. First, iron is taken in, then it gets absorbed in the gut, then it gets transported through blood to different parts of the body where it gets used, and then the excess gets stored, and finally the process of absorption is regulated. First, iron intake. So there are two different sources of iron. You can get iron from animal product. The type of iron you get from animal product is heme iron, and you can also get iron from plant product. The type of iron you get from plant product is non-heme iron, which is also called inorganic iron. Now, the difference between heme iron and inorganic iron is that heme iron is directly absorbed into the enterocyte of your gut. See, there's your stomach and then there's your duodenum. It's in the duodenum where iron gets absorbed. The duodenum, it is lined by the cells of the intestine, which is called your enterocyte. Iron is to be absorbed into the intestine, into the enterocyte, then it goes in finally into the blood and then transported to different parts of the blood. Heme iron is directly absorbed inside the enterocyte. It is directly absorbed inside the enterocyte. However, inorganic iron, it is present in ferric form. This is important. Remember, heme iron is directly absorbed inside the enterocyte, inside the cell lining your duodenum, but inorganic iron is present in ferric form. So what? So this. Inorganic iron is absorbed only in ferrous form, but the inorganic iron that you eat through plant products is in ferric form. So this ferric form of iron first needs to be converted to ferrous form, and then this ferrous form is taken in by the enterocyte. So there is an extra step required for the absorption of inorganic iron. That is why heme iron obtained from animal product gets absorbed much more faster than the inorganic iron obtained from plant product. Okay, again. So I said that there are two types of iron. There's your heme iron, which is obtained from animal product, and then there's your non-heme iron, which is also called inorganic iron, which is obtained from plant product. Your heme iron I'm representing here with the help of color yellow, and I'm representing the inorganic iron which is present in ferric form with color red, and the inorganic iron present in ferrous form with color blue. So once you have taken in animal product, you have heme iron from animal product. Once you have taken in plant product, you have inorganic iron in ferric form from plant product. Now, heme iron, it reaches the duodenum. In the duodenum, there are enterocyte cells or the cells of the intestine. Heme iron is taken directly into the enterocyte cell with no extra step required. Okay, but inorganic iron, which is present in ferric form, first needs to be converted to ferrous form, first needs to be converted to blue, this blue thing, ferrous form, and only then it is taken in by the enterocyte or the epithelial cell of your gut, only then. So in order to convert ferric to ferrous, what should take place? See, there's your 3 plus oxidation number, here's your 2 plus oxidation number. So the oxidation number reduces from 3 plus to 2 plus, or reduction takes place. So ferric needs to be reduced to ferrous. This can be done either with the help of reducing agent or some enzymes which helps in reduction. So there are two ways. First, within the stomach, you have hydrochloric acid, which is a pretty strong reducing agent. So this hydrochloric acid, it reduces the ferric inorganic iron into ferrous inorganic iron. However, there are still ferric iron remaining. So all these iron, they reach the upper part of the intestine or duodenum. In the duodenum, you have heme iron, the ferric inorganic iron, as well as the ferrous inorganic iron. So the remaining ferric inorganic iron is reduced with the help of reductase enzyme. This reductase enzyme is present in the inner wall of the duodenum. So there's the reductase enzyme. This reductase enzyme, it reduces ferric into ferrous. And then this ferrous form is taken in by the enterocyte. Ferrous form is taken in by the enterocyte. One last time. Two types of iron, heme iron and inorganic iron. Heme iron is taken directly into the enterocyte without any extra step. Inorganic iron present in ferric form is first converted into ferrous form by two ways. Number one, with the help of hydrochloric acid present in the stomach. Number two, with the help of reductase enzyme present in the inner wall of the duodenum. And then finally, this ferrous form is taken in by the enterocyte of your duodenum. Okay. Once ferrous form is taken in, this ferrous form is then sent to the other side of the duodenum. After ferrous form reaches the other side of the duodenum, now this iron needs to be transported through blood to different parts of the body. However, for transportation, we again require the ferric form, not the ferrous form. The whole purpose of converting ferric form to ferrous form was only for this much step. For taking iron from one side of the duodenum, from inside the duodenum to outside the duodenum. Only for this much step, iron had first to be converted, inorganic iron had first to be converted into ferrous form. But once this ferrous form is sent to the other side of the duodenum, it again has to be converted to ferric form for the sake of transportation. So to convert ferrous into ferric, what should take place? Oxidation should take place. What type of enzyme do you require? Oxidase enzyme you should require. So you have oxidase enzyme outside. This oxidase enzyme, it converts ferrous into ferric, and then this ferric is transported through your blood. Inside the blood, you have something called transferrin. To this transferrin, at one time, two ferric can combine, and then this transferrin, it transports the ferric ion to different parts of the body where they are either used, for example, in bone marrow, for the process of erythropoiesis, for the process of formation of hemoglobin, for the formation of heme, this ferric iron is utilized. And the extra iron present in blood, it is stored in the liver in the form of ferritin. If there is too much iron, it is stored in the form of hemosiderin. Okay, now that you know the basics, let's look at the same thing in much more detail as per the diagram given in Robbins. So what I'm going to do is take this enterocyte right here and zoom into it. So this is what it looks like. It looks complicated, but trust me, I'll make it really easy for you. Just follow me. First, you have your enterocyte. What is enterocyte? It is the epithelial cell making the inner lining of your intestine. There's your enterocyte, the epithelial cell of your gut. So here I have taken enterocyte from duodenum. Here's the lumen and here's the blood. So there's the lumen, there's the enterocyte, and then there's the blood. Here's the lumen, here's the enterocyte, and here's the blood. Now this enterocyte has two surfaces. One surface is facing the lumen, which is called luminal surface, and the other surface is at the base or basolateral surface. So I've taken the same cell, flipped it, and we have it right here. So we have the luminal surface, which is facing the lumen, and we have the basolateral surface or the basolateral side, which is present at the base of the gut. Okay, so these are the two surfaces. Now let's look at the story of iron absorption. So I said that when you take in iron, you can take two different forms of iron. Number one is the iron obtained from animal product, which I have shown in color yellow. This is the heme iron. Number two is the iron that you can take from plant product, which is the non-heme or inorganic iron. Heme iron present in yellow does not go through any extra step. It is directly absorbed into the enterocyte with the help of a transporter. Since this transporter is for heme iron, it is called heme transporter. Simple. So here's the lumen. In the lumen, there's your heme iron. On the luminal side of the enterocyte, there's your transporter for the heme iron called the heme transporter, which allows for the entry of heme iron directly into the enterocyte without any extra step. But for the inorganic iron obtained from plant product, it is present in ferric form. First, this ferric form is reduced to ferrous form. This is done with the help of reductase enzyme present on the luminal side. This reductase enzyme is present on the luminal side of duodenum. That is why it is called duodenal cytochrome B. So duodenal cytochrome B, it reduces ferric to ferrous. One ferric gets converted to ferrous. Now this ferrous can be taken into the enterocyte. Why should this ferric be converted to ferrous? The reason being, there is a transporter present right here for metallic ions. Which type of metallic ions? Divalent metallic ions. So this transporter allows for the entry of divalent metallic ions into the enterocyte like Zn2+, Cu2+, and Fe2+. And that is why Fe3+ had to be first converted into Fe2+ so that it could pass through the divalent metallic transporter and reach inside the enterocyte. Okay. So after all that, you finally have all the ferric ions inside the enterocyte. Heme iron directly taken in with the help of heme transporter, ferric iron first had to be converted to ferrous with the help of reductase enzyme, and then it passed through the divalent metallic transporter. Now you have all the ferrous iron required inside the enterocyte. Now this ferrous iron should be taken to the other side of the duodenum, or should pass through the basolateral surface. So on the basolateral surface, there is a portal for ferrous iron called ferroportin 1. Portal for ferrous iron, ferroportin 1, which allows for this ferrous iron to reach the other side of the duodenum. Nice. Now we finally have all the iron present on the luminal side, or present in the lumen on the other side of the duodenum. But we have this iron in ferrous form because we required ferrous form to pass the enterocyte, right? But then iron gets transported in ferric form. So we convert ferrous form to ferric form, and this is done with the help of oxidase enzyme present on the basolateral side of the duodenum called hephaestin. So ferrous gets converted to ferric, and then it gets transported with the help of transferrin. One transferrin, two ferric can bind, and this gets transported to different parts of the body. In bone marrow, iron gets utilized for the formation of heme. In liver, excess iron gets stored in the form of ferritin. If there is a lot of iron, there is iron overload, then the storage form is hemosiderin. Okay, now let me show you the same thing in the diagram given in your Robbins. Wait, before that, one small thing. So finally, iron reaches your blood. Through blood, it is sent to different parts of the body where it gets utilized, and the excess gets stored. As the storage form of iron increases, what has happened? See, the blood is saturated with iron. The blood has enough iron. That is why the excess is being stored in the liver. That means the blood no longer requires more iron. It does not require more iron. So what should be done? This should be stopped. More absorption of iron, more entry of iron into the blood should be stopped. How is it done? So once the level of stored iron in the liver, that is ferritin, increases, the liver starts producing something called hepcidin. This hepcidin, it inhibits ferroportin. When ferroportin 1 gets inhibited, ferrous iron can't get to the other side of the duodenum. When ferrous iron can't get to the other side of the duodenum, this ferrous iron can't get converted to ferric and then reach the blood. So the absorption of ferrous iron or iron is reduced. What happens to the iron present within the enterocyte? This iron gets encircled by mucosal lining, and what we get is mucosal ferritin. So this is ferritin, iron stored in enterocyte, not the liver, inside the enterocyte. We get mucosal ferritin. So as time passes, the inner lining of the duodenum gets set off. It gets set off and it comes out in the form of poop. So similarly, along with the inner lining, enterocytes also get set off. Along with the enterocyte, these iron or mucosal ferritin, they also get set off and they get out of your body. Okay. Final revision. So here's the diagram. Your food iron, it's of two types. Heme iron obtained from animal product, non-heme iron obtained from plant product. Heme iron is directly absorbed into the enterocyte with the help of heme transporter without going through any extra step. Non-heme iron, which is present in ferric form, first needs to be oxidized in ferrous form with the help of oxidase enzyme, and then this ferrous form, it passes through the divalent metallic transporter and reaches inside the enterocyte. Now inside the enterocyte, we have all the ferrous ions. This ferrous ion, it needs to be sent to the other side of the duodenum. This is done with the help of a portal which is called ferroportin 1. Now finally we have ferrous ions on the other side of the duodenum. However, iron, it transports or it travels in the form of ferric iron. So first this ferrous needs to be oxidized to ferric. This is done with the help of oxidase enzyme called hephaestin. Inside the blood, ferric gets transported with the help of transferrin. To one transferrin, two ferric gets attached. Then this transferrin takes to different parts like bone marrow where heme production takes place, and the excess of iron is stored in liver in the form of ferritin. As the amount of iron increases, the blood has enough iron. Excess iron is stored in liver. Now in liver there is enough ferritin. The liver starts secreting hepcidin. This hepcidin, it inhibits ferroportin. As a result, more iron can't reach the blood. So iron absorption decreases. So this is how the absorption of iron is regulated by hepcidin released from liver. See, this is what happens. So let's say the amount of iron in the blood increases, serum iron level increases. As serum iron level increases, ferritin in the liver, or the storage form of iron in the liver, also increases. This is detected by the liver. Now the body does not require any more iron. So the liver sends more hepcidin. As a result, there is more inhibition of ferroportin. As a result, there is less absorption of iron. But then let's say there is less serum iron in your blood. It falls down. As a result, ferritin, which is stored form of iron in the liver, it falls down as well. As a result, this is detected by the liver, and the liver starts secreting less hepcidin. Hepcidin level falls down as well. As a result, there is less inhibition of ferroportin. Less or no inhibition of ferroportin. As a result, ferroportin is open and functional, and there is more absorption of iron. This is how hepcidin released from liver, it regulates the absorption of iron. Okay. So the iron that reaches the blood, it has two compartments. The iron that reaches the blood has two compartments. One is the functional compartment, which is obviously the useful iron. Iron being used for formation of hemoglobin, myoglobin, catalase enzyme, cytochrome. And then there is storage compartment. The excess iron gets stored in the form of ferritin. When there is a lot of iron overload, it gets stored in the form of hemosiderin. There are two places where iron gets stored. If iron is brought by transferrin, the iron is being brought by transferrin, this iron is stored in your liver, in the liver parenchyma cells. But then if iron is obtained from destruction of RBC. See, there's your red blood cell. This red blood cell dies after 120 days. What remains is the inner content of the red blood cell, which gets destroyed, and we get iron. This iron is then stored inside macrophages of liver, spleen, bone marrow, etc. And this is what we call the reticuloendothelial system. The reticuloendothelial system is composed of macrophages of different organs in your body like liver, spleen, and bone marrow. Inside these macrophages, the iron obtained from destruction or death of RBC is stored. Okay, regulation of iron absorption. So iron reaches your blood. This iron gets used, and the excess gets stored in the liver in the form of ferritin. Fine. As iron level increases, the stored form also increases. As stored form increases, the level of ferritin increases. That means no longer more iron is required by the body. So we need to decrease the absorption. How does this take place? Ferritin level increases. Hepcidin released from the liver increases. Inhibition of ferroportin increases. Absorption decreases. Similarly, if there is less iron in blood, there is less stored form of iron in your liver, there is less ferritin, so the liver starts secreting less hepcidin, there is less or no inhibition of ferroportin, and there is more absorption of iron to bring iron back to its normal level. Okay, now as I said earlier, your inorganic iron, it is absorbed in ferrous form, not in ferric form. It is not absorbed in ferric form. So let's say you have taken inorganic iron. If this inorganic iron in your body is present more in ferrous form, more absorption will take place. If it is present more in ferric form, less absorption will take place. So factor of increasing absorption and factors decreasing absorption. What will increase absorption of inorganic iron? Obviously, ferrous form will increase absorption. More ferrous form, more absorption. What will decrease absorption? Ferric form, more ferric form, less absorption. So obviously those environment that will maintain more ferrous form will increase the absorption of iron. And what will maintain more ferrous form? Reducing agent. What are reducing agent? Your acids. So more HCl in stomach, more ascorbic acid, amino acid. These acids, they convert ferric form to ferrous form. They reduce ferric to ferrous form. More ferrous form, more absorption. On the other hand, if there is less acid or if there is alkaline form, then ferric will not be converted to ferrous. There will be more ferric and there will be less absorption. Substances like phytates, tannates and phosphates, they make chelates with iron, which decreases the absorption of iron as well. Another is iron deficiency. When there is deficiency of iron, there is less storage form of iron, and more absorption. When there is iron overload, that is excess of iron in the blood, there is excess of stored iron in the liver, there is excess of ferritin, and there is less absorption. Okay, now what are the various factors or causes of iron deficient anemia? Here's your tiny little mouth, and then here's your gut. Iron is taken in, it reaches the gut, and then it gets absorbed. So if there is less iron intake, or if there is less iron absorption, or if there is less wastage of iron due to bleeding, or if there is increased requirement of iron, these can all lead to deficiency of iron in human body. So first, if there is less intake of iron. Second, if the iron is taken in sufficiently but then it is not absorbed. Third, if the requirement of iron in the body increases, so you are not taking in enough iron. Fourth, you are losing blood. Along with blood, iron is also being lost. So iron intake reduces if a person is surviving in a poor economic status. So the person doesn't have money for balanced diet and there is lack of iron in his or her diet. Or if there is lack of availability of iron rich products in the market, that can result in decreased intake of iron. Second is impaired absorption. All these factors, they decrease iron absorption. Ferric form, that is lack of HCl, as a result ferric is not reduced to ferrous, or increased alkaline condition, as a result ferric is not converted to ferrous, or phytates, tannates and phosphates which make chelate with iron so that iron is not absorbed, or if there is too much iron in your body already, as a result absorption of iron does not take place. Either way, so these are the main three. First four. These reasons lead to decreased absorption of iron. Along with that, if there is problem in the gut itself, for example, if there is chronic diarrhea or steatorrhea or gastrectomy, how does gastrectomy lead to iron deficient anemia? See, so there's your stomach. Stomach contains HCl. HCl is required for the conversion of ferric into ferrous. Ferrous is then absorbed by the gut. If you take out the stomach and throw it away, what will happen? There is no more HCl. If there is no more HCl, you have achloridria. When there is achloridria, ferric is not converted to ferrous, absorption does not take place, there is impairment in absorption. Increased requirement during pregnancy, during post-menopausal state of women, and in growing children, the requirement of iron is more than the usual typical requirement. Chronic blood loss. If there is hookworm manifestation, hookworm will continuously suck blood and iron will be lost continuously. That can lead to iron deficient anemia. Then pathogenesis. There are altogether 3 different stages of iron deficient anemia. Stage 1, 2 and 3. First stage. In first stage, In your blood, serum iron level is supposed to go down due to lack of iron in your body. However, serum iron level, it does not go down, or you do not suffer from anemia. The reason being, there is iron stored in your liver. When the iron level, when there is less absorption of iron in the body, this is detected by the liver, and the liver starts throwing away the ferritin reserve. As a result, the iron level in the blood is maintained. The stored iron in the liver goes down, but then this compensates for the iron level in the blood, and the iron level in the blood remains the same again. So what happens initially? Initially, let's say there is less absorption of iron. So the iron level in the blood is supposed to go down. However, there is stored iron in the liver. So the liver start giving away this stored iron to the blood. As a result, the level of iron in the blood is maintained, but then the storage iron, it reduces. This stage is called storage iron depletion. Why? Because there is depletion in storage iron, but then the iron level in the blood remains the same. Serum iron is normal. Transferrin is dependent on serum iron. When there is serum iron is high, transferrin is high. Serum iron is low, transferrin is low. Serum iron is normal, transferrin is normal. So since serum iron is normal, transferrin is normal as well. TIBC is total iron binding capacity. What does it mean? So there's a transferrin. To this one transferrin, two ferric irons, they can combine. Let's say there is no ferric iron in the blood. As a result, this transferrin, nothing is combined. So there's gap here and there's gap here. That means the binding capacity of this transferrin has increased from 0 to 2. Let's say from 0 unit to 2 unit. So the binding capacity is high in first condition or second condition. Obviously, it is high in second condition because there are two empty spaces left. That is called total iron binding capacity. So initially it's normal, but then the stored ferritin level in the liver goes down in order to compensate for the serum iron and to maintain it as normal. Fine, that was the first stage. In the second stage, what happens is that now deficiency in iron starts occurring, but then anemia doesn't occur yet. Anemia does not occur yet because the deficiency is seen in the process of erythropoiesis. So during erythropoiesis, what happens? There's your stem cell. From this stem cell, myeloid progenitor cell. From this erythroid series, and then finally erythrocyte is formed. Or basically there is a series of cells that finally lead to the formation of erythrocyte. This series of cell, in this series of cell, the cytoplasm contains hemoglobin. Now that there is deficit in iron, these cytoplasm, they become deficit of hemoglobin as well. But then the erythrocyte is yet not formed. Erythrocyte, anemic erythrocyte or iron deficit erythrocyte is yet not formed. The effect is seen in erythropoiesis. The effect is seen is erythropoiesis, not in RBC yet. So this is second stage where there is iron deficient erythropoiesis, where erythropoiesis is suffering from deficiency of iron, but then anemia has yet not occurred. So what happens here? Obviously serum iron level goes down because there is deficiency of iron. Since serum iron level goes down, transferrin also goes down. But then we have transferrin with empty spaces because iron is not there. So total iron binding capacity increases. Total iron binding capacity increases. Ferritin obviously remains low. Okay. In third stage, finally, the effect of deficiency of iron, which was seen in erythropoiesis, is finally seen in the red blood cell. That is now red blood cell with less hemoglobin concentration is formed. And these red blood cells, they are smaller in size, microcytic, and the peripheral red is less than 2/3. The central pallor is more than 1/3. So hypochromic. You get microcytic hypochromic anemia. This is stage 3 or frank iron deficiency anemia. So that's the pathogenesis of anemia. What's the series? First, the iron absorption is less, so the level of iron in blood is supposed to be less, but then the liver has stored iron. This stored iron is given to blood. As a result, the blood iron level remains the same, but then the stored iron level goes down. This is stage 1 or storage iron depletion, where there is depletion in storage iron, but the serum iron level is maintained. Then what happens? Now the storage iron level, the storage iron is gone. You have iron in the blood. This iron is utilized for erythropoiesis. However, since there is no more absorption of iron taking place, the iron for erythropoiesis is lacking. There is no more absorption. There is no more absorption, so there is less iron for erythropoiesis. No more absorption, less iron for erythropoiesis. As a result, erythropoiesis lacks iron. This is iron deficient erythropoiesis. Finally, erythrocytes are formed at the end of erythropoiesis, and these erythrocytes, they lack iron, they lack hemoglobin. So peripheral 2/3 is thinner, it is less than 2/3, and central pellar is larger. You get microcytic hypochromic red blood cells. Okay, now clinical features. You can mention all the general features of anemia, that is lethargy, the pallor, as well as old age problems related to heart. Then you have specific features of iron deficient anemia seen at 3 different places. Number 1, nails, where spooning takes place, which is also called koilonychia. Then tongue, where atrophy takes place and swelling takes place. This is called atrophic glossitis. And the angle of the mouth, where chelosis or angular stomatitis takes place. There's a syndrome called Plummer-Vinson syndrome. It is a collection of clinical features. So in Plummer-Vinson syndrome, collection of clinical features due to deficiency of iron takes place. So there's a woman of age 40 to 45 post-menopause suffering from iron deficiency. See, I said earlier that one of the causes of iron deficiency anemia is increased requirement. There is more requirement of iron by the body. As a result, the requirement is not fulfilled by the regular intake of iron. The normal intake of iron is not enough. The normal intake is not enough. And this is seen in post-menopausal women as well. So what happens after menopause is the requirement of iron increases. As a result, the iron demand of the body may not be fulfilled in women, and she might suffer from iron deficient anemia. Along with iron deficient anemia, some other clinical features are also seen, and this forms the Plummer-Vinson syndrome. Like what? So there's the upper esophagus, lower esophagus, and stomach. In the upper esophagus, wave is formed. Due to this wave, swallowing of solid food becomes difficult. So esophageal wave formation takes place and swallowing becomes difficult or dysphagia. This triad of clinical feature marks Plummer-Vinson syndrome. So there is deficiency of iron leading to iron deficient anemia. There is formation of wave in the upper esophagus, so esophageal wave, due to which there is difficulty in swallowing solid food, so there is dysphagia. Along with that, your typical features of iron deficient anemia like chelosis and atrophic glossitis. Chelosis and glossitis is also seen. The syndrome is also precancerous because it can lead to cancer of tongue, hypopharynx, as well as esophagus. One small concept. So this thing that was formed inside the esophagus is wave, but if on the outer wall of the esophagus a swelling occurs, or outer wall of any part of the gut swelling occurs, that's a diverticulum. Okay. Lab diagnosis. Number 6. Lab diagnosis. So under lab diagnosis, there are 3 different findings for all sorts of anemia. Blood finding, bone marrow finding, and biochemical finding. So you take a person suspected of anemia, you draw blood, make a blood smear on a slide, observe it under a microscope, you will find these. You take the blood sample and then perform CBC, you will find these. You take the bone marrow, check for cellularity, erythropoiesis, and marrow iron, you will find these. And you take the serum of the person and perform biochemical test, you will find these. First, blood findings. So under a microscope, upon observing the red blood cells of iron deficient anemia, you will find that the size of the red blood cell is smaller than small lymphocyte, microcytic. The peripheral red is less than 2/3 hypochromic. The cells are of different sizes, anisocytosis. The cells are of different shapes, poikilocytosis. The cells are ring-like in structure, ring or pessary cells. Again, so the cell is smaller, microcytic. The peripheral red is less than the central pellar or hypochromic. Cells of different sizes, anisocytosis, and cells of different shapes, poikilocytosis. Then you have RBC indices. All RBC indices, they fall down. There is deficiency of iron, so obviously hemoglobin goes down. The mean corpuscular hemoglobin goes down, and the mean corpuscular hemoglobin concentration also goes down. There is decrease in RBC production, so there is decrease in packed cell volume as well as decrease in mean corpuscular volume. Then there is bone marrow finding. In bone marrow finding, first cellularity. See, the production of RBC has decreased. The number of RBC has decreased. So to compensate for the decrease in production of RBC, hyperplasia takes place in the bone marrow. So during formation of RBC, what happens? There's your stem cell. From this stem cell, myeloid progenitor cell is formed. Then you have your erythroid series. Which contains a series of cells, and finally nucleus comes out, reticulocyte is formed, and RBC is formed. So due to decrease in production of RBC, there is increase in myeloid progenitor, due to decrease in number of RBC, there is increase in number of erythroid cells. To compensate for the decrease in number of RBC. See, RBC number is decreased, so the body makes more erythroid cells to increase RBC. This is a compensatory mechanism. As a result, what happens? Myeloid by erythroid ratio goes down. Why? See, myeloid number remains the same, but erythroid number, it increases. So same by increase, the ratio is decreased. This is more, this increases, so the ratio decreases. Myeloid by erythroid ratio decreases. Erythropoiesis. Cytoplasm lags behind nuclear maturation. Why? So normally nucleus matures, along with it cytoplasm matures. But in iron deficient anemia, there is lack of iron, there is lack of heme, there is less production of hemoglobin, so cytoplasm lags behind. Cytoplasm is yet to mature, but the nucleus has already gone front. The maturation level of nucleus has already gone front. So this nucleus reaches this level of maturation, but the cytoplasm here is still the same as cytoplasm here. So the maturation of cytoplasm is lagging behind. Then marrow iron. Since there is decrease in level of iron, obviously the iron stored in the bone marrow also decreases. Iron in bone marrow is detected with the help of a typical special stain called Prussian blue stain, which stains iron blue in color. Since there is decrease in iron level, there is also decrease in Prussian blue stain. Let's look here. So this is your normal iron store in bone marrow. This is your reduced iron store in bone marrow. You can see lots of Prussian blue stain. You can see scanty Prussian blue stain. Finally, biochemical findings, the same stuff that I explained earlier. In case of pathogenesis. These are the biochemical findings that you are going to get. Obviously, serum iron is going to go down. When serum iron falls down, transferrin falls down. Transferrin, they are empty. So total iron binding capacity increases. The stored iron in the liver goes down, so ferritin goes down. Treatment. So iron deficiency anemia can cause due to some other disorder. For example, in case of chronic diarrhea, or maybe there is acute blood loss during menstruation, or maybe due to piles. So due to these reasons, there is loss of blood. When there is loss of blood, there is loss of iron, and this leads to iron deficient anemia. So first we need to get rid of these disorders in order to cure iron deficient anemia. But then if anemia is caused due to actual deficiency in iron, like deficiency in intake of iron or maybe absorption of iron, then we can perform either oral therapy by giving salts of ferrous, Fe2 plus salts, because Fe2 plus gets absorbed easily, or you can also give iron dextron by IV route.